Okay. So today we're going to talk about placement in substance use disorder treatment. This was originally intended to be a lecture for our fellows by their request, but I realized there have been a few changes to this recently, and I thought it was something that we could probably talk about together, and hopefully everyone would learn something from the updates if you were already familiar with it. I have no disclosures to discuss. This lecture primarily revolves around the ASAM criteria. The ASAM criteria were designed to do a few things, but to guide level of care decision making for our patients and decide when you get a patient what level of care they'd be best suited at in substance use disorder treatment. They're designed to encourage a shift from a few things instead of just saying, well, somebody has an alcohol use disorder, right? This was designed to say, well, we should take into account more than that, right? We should take into account multiple dimensions of somebody's alcohol use disorder or multiple things in their life or other problems that might be affecting the illness and use that to come up with a level of care treatment. And also, they developed the criteria to make treatment more more clinically driven and less program driven. And really the other bullets are similar. They go from a variable length of service, from fixed length of service, and from discrete levels to a flexible continuum of care. So a lot of times, classically the treatment would be, well, you have an alcohol use disorder, let's put you in a 28-day program, right? Or 30-day program or whatever length program. And ASAM decided that was kind of wasteful. That might be appropriate for some people, but it might not be appropriate for some others. So a big part of developing these criteria was to kind of individualize patient care based on what the specific patient might be needing. This is the ASAM criteria textbook. The 4th edition was just released last year, and there are some important changes in it. Of note, only the first volume has been released thus far, which focuses on adults, but there's going to be other volumes released on special populations, on pregnant females, and then I believe there's one on adolescents as well that's still coming out. Some of the big things that they updated the dimensions, so the classic 6 dimensions that you may or may not be familiar with. We'll go over those, and subdimensions, but they changed those as well. They've updated the continuum of care, so your kind of classic levels of care and what levels they put those on a continuum. Some of those have been updated, and they've added a core components section. So we'll go over all that. One thing to keep in mind, though, with all this is that the ASAM criteria kind of operates in an ideological framework that is ideal, right? It's used in most states, but it's not currently used in all states. It's used by many payers, insurance payers, which have a big, can really factor into our patients' treatment, what treatment they're getting. But there's pretty variable interpretation of these, and many of them are kind of up for debate. I learned this firsthand as part of my fellowship last year. I worked at a partial hospitalization program, because that's what it was called at the time, with housing, and part of our job was to do peer phone calls with insurance companies, and I learned that firsthand that there is a degree of subjectivity to this, and what a patient needs based on these criteria might vary depending on whether you're seeing the patient in front of you and then what the insurance company wants to pay for. So they are used by the Department of Defense as well. As part of our frustration with our healthcare system, I have decided to theme this lecture on ICD codes, because I've seen a few lately that are pretty funny. So this first one is, I don't always get sucked into a jet engine, but when I do, I use that ICD code. ASAM is big on unbundling services. So services are often bundled together for billing purposes. What that means is, for example, somebody's in a residential program. the insurance company might pay for them to be to have psychiatric consultation once a week, let's say, while they're there. Well, not all patients might need that, right? That might be wasteful for some patients, and some patients might not need to be seen by a psychiatrist at all while they're in a residential program. So basically unbundling those services in a more individualized way for patients that's more cost effective is what they're trying to get at. Another example would be like a high intensity outpatient program, which used to be called PHP with housing, as opposed to residential. So if somebody doesn't per se need the amount, the actual physical, like locked structured environment of a residential program, but could do with more therapy than you could provide in like an IOP or an outpatient program. Maybe that would be an option that they could do with housing. They might be able to get housing separately while participating in the high intensity outpatient program. So again, minimizing costs, minimizing unnecessary services, and hopefully with more individualization is the ideal goal. ASAM criteria also pushes for early intervention and prevention, as opposed to fragmented services and incarceration. I like the way that is said there, that there's a big focus towards preventative treatment before people get involved in the criminal justice system, and using the criminal justice system as treatment. Younger populations, getting them involved at a younger age, hopefully that paying dividends down the road. There is and they also vouch for greater sensitivity to substance use and mental health in the criminal justice welfare systems once people are getting there. Core components of the ASAM criteria. So this is basically a flow chart that tells you what happens with the ASAM criteria. Your patient will enter treatment. Typically, they'll have some kind of intake or new patient visit. That's when you would conduct your level of care assessment. So you can see that's the first green circle there. Then you move on to your decision rules after that. So you'd use those criteria that you've had to make some kind of decision for a patient, where they belong on this continuum of care, and then hopefully get them to that level of care. Also newer in this addition too is emphasizing the reassessment point. When somebody reaches a certain point in the continuum of care, reassessing them. Do they need to go to a higher level of care? Should they continue with this level of care, or can they downgrade to a lower level of care? So these are the actual criteria, and these are the changes that have been made in between the third and fourth edition that was released late last year. So you can see the first three dimensions largely are the same. They toyed around with the names a little bit, but for the most part, they are the same. Dimension 4 has been deleted, readiness to change, and I'll talk about that when we get to 6. Dimension 5 has been carried over into Dimension 4 with a very similar sounding name, and then Dimension 6 has been carried over into Dimension 5 with a very similar sounding name and purpose. Big reason that they got rid of Dimension 4 was that this was our readiness to change. So, for example, we might say that somebody we might use the stages of change, for example. Well, they didn't have to, but that was one way of doing it, to say, oh, this patient is pre-contemplative or they're contemplative. And a lot of times that didn't really factor into what actual recommendation we'd be giving for patients, right? We might say, based on their criteria, that they need a certain level of care, and they might say, well, no, right? I'm pre-contemplative, right? There's not much point in actually talking about that. So they don't recommend using that as part of the actual care recommendation. So right now what they're saying to do is use these dimensions 1 through 5 to come up with a level of care recommendation. And then they added a dimension 6. So once you've used 1 through 5 to come up with that level of care recommendation, using dimension number 6, which is now patient-centered considerations, to say, well, they didn't want to do that, or patient preferences, or they couldn't do that, right? They couldn't afford it, or what actually happened with that level of treatment. So that's been a pretty major adjustment in the criteria. We'll go through them too, one by one. So the first one is intoxication, withdrawal, and addiction medications. And you can see, based on always this information is going to be based on your subjective and your objective data, or available information, and you might not always have all the information between those two things. So you do have to always keep in mind the potential for unexpected intoxication or withdrawal. For example, patients might be using substances that wouldn't routinely show up on a urine drug screen. For example, fentanyl is not included on many, or designer benzos online might not show up on a lot of drug screens. Intoxication is also important too. For example, if you just walked into a lamppost, or if you walked into a lamppost for the second time and needed an ICD code for it, that might factor into your treatment too, right? Because you might have some medical issues too that you might need to get addressed. So those are some ways that those will contribute to your levels of care. The second dimension, the one that the new one too that they added on there, they kind of tacked on, is addiction medications too. Many people did talk about that in dimension 1. With regards to craving, I frequently heard that kind of tacked on, although it's not mentioned specifically in there, but mentioning that somebody is on, say, naltrexone or buprenorphine or acamprosate or whatever they're taking, but mentioning that in your dimension 1. Next is biomedical conditions, which sounds pretty similar to what it used to be, biomedical conditions and complications. Biomedical conditions would be things, physical health or pregnancy concerns. These are the subdomains they have it divided out into, or sleep problems. How might these impact level of care? So pretty significantly, right? If you have somebody who has chronic pain, we see that frequently as comorbid with opioid use disorder. So that's something that frequently can interplay with our patients' treatment. Patients who have severe medical issues, let's say oxygen dependence, is one to think about. If you're wanting a patient to go to residential care, a lot of times residential care facilities can't accept patients who are on oxygen. They just don't have the needs that, say, like a nursing home would have. They don't have the nursing support to be able to handle patients who have significant medical needs there. So certain levels of treatment might not be an option for your patient. If you have a patient, let's say they come into your dual diagnosis unit or detox, and they're withdrawing from alcohol, and they're confused and they're ataxic and have ophthalmoplegia, and you think they may have a Wernicke's encephalopathy, well, then outpatient is not something that they're going to be able to achieve for quite some time, right? You're going to need to give them some IV Thiamine first for a few days to see if they kind of perk up first before you can get them anywhere. Same goes for that ataxic patient, or just a debilitated patient who's debilitated from drinking or from using other substances and is confined to a wheelchair. Let's say, for example, they were struck by a duck and needed an ICD code for that. Then they might be that would limit their residential care as well options, as many places wouldn't be able to handle that. There are ways around it. In my fellowship program, we did have some patients who, if they had the means, were able to would hire people to come take care of them while they're in rehab, and that's great if you have the means to do that, but not everybody does. Patients who are jaundiced is another common complication of alcohol use disorder, and it's pretty hard for somebody to go to some kind of residential program if they're suffering from severe liver disease. We frequently have these patients, and they'd be bouncing back and forth between the hospital rehab, and it's hard to get a whole lot done if you're that sick. My fellowship program, we also had a lot of patients who were in the transplant program who had received transplants, who were going to receive transplants for liver disease, and this was frequently challenging to get these people actually in one place long enough that you could treat them. Dimension 3 is emotional, behavioral, or cognitive conditions and complications, which has been updated to psychiatric and cognitive conditions. So sounds pretty similar. Active psychiatric concerns. So obviously any psychiatric emergency is going to change your level of care right away, right? Because people are going to have to go to a psychiatric hospital if they're having suicidal thoughts. with the plan and intent, of course. Homicidal ideation or any kind of psychiatric emergency, psychosis that's is severely debilitating or something like that. These people are going to have to go to the hospital, get stabilized first before they can go to a lower level of care. People with disability, these can be extremely challenging patients in substance use disorder. People with psychiatric disability or with cognitive disability, cognitive functioning problems. For example, autistic patients, patients with dementia. It can be extremely difficult to get these people to engage in groups. And a lot of times it's not really an option for them. So it can be a challenging patient population to work with when a lot of group therapy or psychotherapy really isn't an option for them. Next is substance use related risks. What formerly was relapse, continued use, or continued problem potential. So this dimension focuses on the likelihood of risky substance use and likelihood of risky substance use related behavior, the two subdomains they have it divided out into. So for example, if you have somebody who came in and it has extremely risky behavior related to substances, for example, let's say they've overdosed recently, or let's say that they use IV drugs. Those are going to be things that are, they're at risk for contracting HIV or hepatitis C or something like that. That's going to make their substance use riskier. And then you also have to consider, outside of just the medical effects, but what behaviors a substance use disorder is intertwined with. So for example, many of our patients become involved with domestic violence, or they'll become involved with human trafficking, those kinds of things. Next is the recovery or living environment, which has been changed to recovery environment interactions. So recovery environment interactions focuses on your ability to interact and your ability to succeed with regard to substance use in the environment that you're at. The subdomains that they have it subdivided out into our ability to function in your current environment. So that would be things like, do you have employment, do you have stable housing, safety in your current environment. Same thing also ties into safety a lot of times. Support in central environment, and then cultural perceptions of substance use are all the other subdomains. And we frequently see this, being a big problem in our patients, especially like our homeless patients. It's going to be pretty hard for them to stay away from substances if the guy in the tent right next door is also using their substance of choice. We can also see improvement in this category too. And we like to see that when we have patients that are stable. Sometimes we'll see them kind of start to get some of these things back, and hopefully they're getting their jobs back, or getting custody of their children, or relationships are improving. And that's hopefully one of the brighter sides of our job, is being able to see these things happen. You also have problems with spouses or family members in the house, right? If they're also using, let's say they're drinking alcohol, your patient's dealing with an alcohol use disorder. Well, it's going to be pretty hard for them to quit drinking if their husband is drinking a quart of whiskey every day. It's going to be pretty hard for them to stop too, without taking them out of that environment or changing that environment. And then the last is dimension 6, which is the new one. And this is partially taken from what used to be dimension 4. So remember, you're going to take your dimensions 1 through 5, use those, and get the actual recommendation for a level of care. And then basically move on to dimension 6 and say, okay, well, here's what actually happened, right? So after taking into account their person-centered considerations, you're going to take into account patient preferences, right? So some patients may say, no, I'm not ready for that level of care. Some may say, I can't afford that level of care. Some actually cannot afford that level of care, or don't have any resources available to pay for a level of care. Insurance can be an issue here, or it can be just people not wanting to pay for it. And then they also include, I think pretty notably, need for motivational enhancement. So this is where you can kind of lump in patients who are maybe pre-contemplative or contemplative here. That we didn't do anything for them. We didn't get them to that level of care because they didn't want it, but hey, we did give them some motivational enhancement today, or this is what we're working on as far as motivational enhancement. So I think this is kind of an important change from the old dimension 4 into this dimension 6. So here's kind of a full list of the new dimensions and their subdimensions. You can see the first one, dimension 1, intoxications and associated risks, withdrawal and associated risks, and addiction medication needs. The second one, the blue ones that are highlighted are the ones that they recommend using to actually get your level of care. The other ones, I don't want to say they're not important, but they don't recommend those being used as much in the actual level of care. So you can see that dimension 6 does not have any of the blue text. Dimension 2, the subdomains are physical health related concerns, pregnancy related concerns, and sleep problems. Dimension 3, active psychiatric concerns, persistent disability, cognitive functioning, trauma exposure and related needs, psychiatric and cognitive history. And dimension 4 is substance use related risks, likelihood of risky substance use, likelihood of risky substance use disorder related behaviors. Dimension 5 is ability to function in current environment, safety in your current environment, support in your current environment, and cultural perceptions of substance use. And then the subdomains for dimension 6 are patient preferences, barriers to care, and then, like we talked about, the need for motivational enhancement. Okay, so let's say we've done our criteria. We've come up with this great level of care, and this patient says, I'm absolutely going to do it, and I have the resources to do it. We have to actually give them a level that they say they're going to do. So this is where ASIM tells us the actual levels of care. They describe it they describe it as a continuum of care rather than as discrete levels, so that it's flexible. And programs are, and I think that's appropriate because programs really vary, right, in what they offer. It's hard to kind of put a price tag on a program exactly and what exactly it has, and just give it a number on the system, because most programs fall somewhere in between. They recommend the least intensive level of care that suits the patient's needs, whatever that is, because anything more than that would probably be wasteful. Reassess and de-escalate that level of care as soon as possible. Relapse doesn't necessarily mean a higher level of care, right? Just because somebody's not succeeding at your level of care doesn't mean that there isn't something you can change about your level of care. So let's say you have a patient who has housing instability, and because of peer influences there is not doing well with regards to their substance use disorder. Well, you may not need a higher level of care. Well, you may need eventually to escalate to residential level of care. You may be able to fix that at your own level of care if you're able to get them housing. So that's a reason not necessarily to escalate from care if there's something you can do at your current level of care to take care of that patient. So here's the actual continuum of care. You can see at the bottom, they kind of give an honorary mention to recovery residents, and then they move forward. There's 4 big levels. Outpatient is level 1. Level 2 is IOP, and what used to be PHP is now high intensity outpatient program. Level 3 is residential, and then level 4 is inpatient. So first we'll talk about at level 1, the blue second from the bottom there, the outpatient levels of care. And level 1.0 is long-term remission monitoring. This is a new level that they threw in with a kind of emphasis on getting our patients that are doing well, monitoring them and making sure that they aren't having needs and that they are continuing to do well. It also emphasizes screening and screening people and identifying substance use disorders early. Level 1.5 is outpatient therapy. So this is mostly like psychotherapy without medication management. So typically wouldn't be seeing a medical provider for this. They'd be seeing behavioral health. And then 1.7 would be where you start to add in behavior, or you start to add in medical providers or medication management with the medically managed program. So our program at ETSU probably falls most closely into 1.7 or something like that, something in the high ones. Next is IOP and high intensity outpatient programs. So high intensity IOP and IOP, they kind of changed this. They changed PHP, which was formerly level 2.5, into high intensity outpatient. They changed the name just because partial hospitalization was confusing. It really had nothing to do with hospitalizing people. An intensive outpatient program, you can typically expect to be seen 3 to 4 days per week for about 3 hours per visit. Typically, it's pretty heavy on group therapy. It's most of it. High intensity outpatient, or what formerly was PHP, is essentially pretty similar, more groups, but it's much more time. So 20 hours per week. Typically, those are 5 days a week. Could be up to 7 though. Next is level 2.7, which is medically managed intensive outpatient. So here's where they'll be doing one of these, either 2.1 or 2.5 levels of care, but they'll also have some kind of medical management going on from a provider. Down in the left is right is a picture of our IOP program in locally. Next is residential. So residential, there's 3 levels. There's 3.1, clinically managed, low intensity residential. I don't have much experience with this level of care. I haven't seen a residential program where they only do 5 hours a week. But if anyone has any experiences, I'd be happy to hear about them. What I've more seen is at the 3.5 and 3.7 levels of care. These are more high intensity residential, so you're getting a lot more hours per week and with group therapy, and then clinically managed as well too. So people are getting medications prescribed. The difference between 3.5 and 3.7 is 3.7 is adding 24-hour nursing care with a physician on call. Residential programs wildly vary based on essentially what kind of program people want, what they can afford, and what they're willing to pay for. You can have anything from our, kind of our local program here is pictured Willow Ridge, pretty modest programs, which are much more common. Anything up to, you can go out, spend $1,000, in a day in a place in Malibu, at a cash only program out there where they'll do equine therapy, and it's questionable whether that really improves your outcomes that much, but it's there for people that can afford it, and people will do it. They'll see celebrities and kind of hop on board with trends and go to swanky rehab. So they exist. You can have a private chef and live the high life through your rehab. That being said, that's not very common. The most common programs are ones that are do have some kind of insurance coverage. This inpatient. So these would be our patients who need a very high level of care. Typically, this is not for very long. This is for long enough to get through some acute medical need or psychiatric need. So like some common things we'd see would be patients who have had seizures, patients who are really high risk for seizures, or maybe had a seizure out in the, hopefully not, but had a seizure, had a withdrawal seizure out in the environment they were in. And now need to be hospitalized for withdrawal management. You can have patients who are medically ill from a variety of things related to substance use disorders. One, for example, would be like liver issues, liver transplant. You could be struck by a killer whale or an orca. And if you are, your doctor's in luck because there's an ICD code for that. And then you also have to decide whether a patient is more appropriate for a dual diagnosis unit or detox unit. versus a medical hospitalization. So there's kind of a lot that goes into that. But just keep in mind that many dual diagnosis units or in psychiatric hospitals are essentially outpatient clinics with locked doors. They just don't have the capability there to really keep up with a lot of medical issues. Next is kind of gets an honorable mention is opioid treatment programs, which are federally licensed to dispense methadone, but often have availability of other medications as well for opioid use disorder. These they don't actually get a spot on the ASM continuum, but if I had to put them somewhere, it would probably be in the high 1 point somethings. Or low 2 point somethings, which would be like in the outpatient category. It is mostly done outpatient, but sometimes the counseling can be pretty intense with it. And sometimes that's mandated as well too. It kind of depends on the program. Our local one is called Over Mountain Recovery here. Office-based opioid treatment. I should mention about opioid treatment programs. They're good for patients that need a lot of structure. For patients that would benefit from showing up every day for their dose, every day for therapy, or something along those lines. So patients that do well with that kind of structure typically do well in these programs. Office-based opioid treatment, or OBOT is another term you'll kind of hear thrown around. It basically just describes any practitioner who describes medication for opioid use disorder in a setting that is not an OTP, which is a lot, right? Could be just anybody out of their primary care clinic doing this. The actual designation for calling it an OBOT varies by your state. So in Tennessee, you have to get over 150 patients to be considered an OBOT. Once you do, then you're an OBOT, and you have specific requirements that you have to fulfill. Sometimes this varies by state. They will require or mandate counseling, case management services, frequency of visits. Those are all things that can mandate in a program, and these programs don't offer methadone. Another one that did make it onto their chart is recovery residencies, and this is new in the 4th edition. But they talked about sober living, halfway houses, domestic violence shelters. Those are examples of places that people can go, and it's really just a residential environment for people in recovery, frequently early recovery. While things are kind of getting stabilized, it gives them a place where they can go and nobody's using, or at least ideally nobody is using. They do drug testing while you're on there, and there are some pretty strict rules as to what you have to do to stay there. Some of the larger ones include like Oxford House is one of the bigger ones nationwide. Many places have an Oxford House available, but there are many others as well. Employment resources, so they frequently have case management at these places to help people get back on their feet. And then they do have varying acceptance of medications for opioid use disorder, for example, buprenorphine or methadone. We've actually had good luck recently. Until very recently, we seem to have had issues here with some of our sober living places accepting medications for opioid use disorder, but thankfully that seems to have changed, and some of them are more accepting now. A caveat to these programs is that you frequently need income to live there. They'll charge you rent, so that's a barrier for a lot of people. A lot of people end up being able to do it with a disability check or something like that, or Social Security. Those are things that you can use to cover the income for it, but finding income to get you the first month's rent a lot of times can be challenging. Criminal justice settings probably shouldn't be mentioned here, but unfortunately have to be mentioned here because incarceration is something of a residential environment for our patients. Although there is varying access to substances that they may be using there while they're incarcerated, and also taking into account reintegration after release, hopefully releasing these people in a way that will be conducive to them getting continued substance use treatment and reintegrating into society after they've been released from incarceration. One of my favorite ACD codes is swimming pool of prison as a place of occurrence of the external cause, which leads me to ask several questions. What was the external cause, right? Why was there a swimming pool in the prison? Is also a good question. And what was the place of occurrence, right? Or what was the actual thing that occurred while they were in the swimming pool? In the right is actually a picture. I Googled this because I really wanted to know. And there's actually a prison in Venezuela that got taken over by drug gangs, and they had made a swimming pool in prison, which is interesting, until the federal authorities came and busted that little operation up. The last one, I think this is the last one to mention, but is faith-based programs. These are often residential programs. People will go stay there. The caveat is that they have typically some kind of work requirement. So you do have to have somebody who is able to work medically to go to them frequently, as they have some kind of requirement. It may not be backbreaking labor. Sometimes it is. Some of these programs are like out on farms, or and people have to do some pretty hardy manual labor. Sometimes not. Sometimes they're flexible and they can find things for people to do if they are maybe not 100% physically fit for duty. But an important caveat is that they're free too. So people who maybe don't have that, disability check or social security check to pay for sober living, this might be an option. It is important to note that there's no medical care offered at these places, and a lot of them will not accept patients that are on any kind of psychotropic, which takes out a large segment of our population, right? And it also brings up the unfortunate scenario of frequently having to choose between keeping a patient on psychotropics and sending them to a faith-based program. But programs it's frequently group-based, and then there's often a religious component too. So some of the limitations, we kind of brushed on this earlier, but they kind of, I guess, got more, let's say, forthcoming, but they acknowledge this more in the latest edition of this, with the Dimension 6, right? Is that this, you're going to come up with this recommendation and it's idealistic. It's not going to take into account patient preferences or clinical, what reimbursement guidelines you might have from insurance, and then just all the real world dilemmas of access, availability of services in your specific area, and what courts may or may not be following these guidelines. That's it. This is one of my favorites too, the burn due to water skis on fire. Just in case you ever have a patient who has that happen. I do have a couple of cases here, which I think we have time for. Is that right, Veronica?
Yes, we do. If right before you continue, if a couple more people have joined, so I'm going to let them introduce themselves, and then we can hop into your cases, and before that as well, to see if there's any kind of questions or anything. Thank you, Jack. That was a great presentation, and I love the ICD-10 codes of, especially the ORCA, the contact with ORCA. If you need to know it, I put it in the chat. I Googled it. I didn't believe you. Okay, let me see. Let me get all the way. Okay, Hannah Winston, if you can unmute and introduce yourself, please. Give me a second. There's a number, the 423-552. If you can unmute and introduce yourself.
Can use the *6 if you want to unmute on the phone.
It's okay if not.
I think that the 3.1 that you mentioned shouldn't be 5 hours per week. It should be 5 days per week, I believe.
Okay.
And that's a residential, because if you're looking at the the level of the care that we discussed in level 2, Some of them is 20 hours per week for the IOP, and residential should be a little bit more. And I think that is the like 5 days a week they will come and they go home on a weekend and they stay in a residential, and that's a 3.1 that you mentioned on that level.
Okay,
And also
thanks.
I want to just say, if you want to simplify this dimension, the first one is to recognizing if the patient needs the inpatient detox or preventing any kind of the withdrawal or intoxication treatment, and then biopsychosocial in 2, 3, and 5, and then you have the high-risk substance use on the 4th, and the 6th would be what would be working for my patient. So if you're looking at the 6th, dimension, it's a biopsychosocial approach that we always, do in a evaluation of the patient.
Thank you, Dr. Heil. Is there anybody else that has any questions or comments based on Jack's presentation before we get into a case? Go ahead, Jack, with the case.
You got it. I have 2 in here. I don't know if we're going to make it to 2, so we'll start with 1. This is a patient I had in fellowship. I'll read it and then we'll kind of do we'll try and get together and see what we think about doing dimensions for this patient and where we think they should end up. The case is about an 18-year-old female with a history of moderate to severe autism spectrum disorder, anxiety, and psychogenic non-epileptic seizures. Who was transferred voluntarily from the emergency department to your psychiatric dual diagnosis unit. She was found wandering in the national forest, intoxicated with methamphetamine, having psychosis, mostly auditory hallucinations, and transported by law enforcement to the emergency department, where she was involuntarily committed due to psychosis, which has since resolved. She is unwilling to provide much useful history, but a urine drug screen is positive for methamphetamine, fentanyl, and cannabis. A urine to pregnancy test is unexpectedly positive, which is a surprise to her, as well as testing for syphilis, gonorrhea, trichomonas, and chlamydia. She lives in a tent in the national forest, and when contacted her mother states she was kicked out of her house about a year ago due to drug use. She's not displaying any opioid withdrawal symptoms at present, although she is tired. So I'm going to bring up the criteria here. We can kind of go through it. Anyone have any ideas for dimension 1? It's intoxication, withdrawal, and addiction medications.
Well, I'll say that intoxicated with the methamphetamine and had a psychosis, but that resolved after they took them.
Yeah. And she's tired now, so maybe she's withdrawing a little bit from methamphetamine, and could withdraw a little from cannabis too, but no real withdrawal that we anticipate right now. Although the fentanyl, we might have expected some withdrawal, but she's not having any. Next one would be dimension 2, biomedical conditions. What do we have for that? Oh, come on, don't make me answer my own question.
If nobody answers, I will point the finger on someone. Brenna, go ahead and give us the answer for the second one.
Oh, okay. She's pregnant and she has also sexual transmitted infections.
Yeah, all right. So we got some pretty significant concerns there, right? She's pregnant.
Also seizures, non-epileptic seizures.
Yeah. And she's, and this being pregnant unexpectedly is gonna require her to need a lot of care, right? She's gonna need prenatal care, and she's gonna need to be treated for these infections. Psychiatric, the third dimension would be psychiatric and cognitive conditions. What do we have there?
That's for Susanna. Susanna. I point my finger to our good nurse practitioners in psychiatry.
Not a nurse practitioner, but I'll say autism spectrum disorder and anxiety.
Mm-hmm.
Yeah, all right. We have some autism spectrum disorder, which pretty severely limited this patient's ability to really communicate with us or communicate effectively with us. Anxiety, and then the PNES would probably be more of a medical thing. But then she was psychotic as well too, so substance-induced psychosis, which has since resolved. Let's do dimension 4, substance use related risks.
Homeless because of her substance use disorder.
Yeah, so she's homeless due to it. One of the first, questions we had was, gosh, with all these STDs and unexpected pregnancy, like what's going on in the national forest in this tent, right? With all these drugs involved and probably something bad, is the answer to that question. So yeah, she's having some significant risks related surrounding her substance use, and definitely in a very bad environment. It puts her in a very hard situation. Recovery environment interactions, I can talk about that. So, we basically just said it, right? She's homeless. She's burned bridges with her family, who might kind of be her only support. And then dimension 6 too is difficult with her too, because we're talking about patient preferences. When we initially got this patient, she was involuntary. So she definitely didn't want to be there. In Florida, they have involuntary substance use treatment. So the patient was brought in involuntarily, and we kept her there for a while involuntarily, too. And then there, became a question of, does she even have decision-making capacity to be making the decision to be leaving treatment. So we had to deal with that too. And then barriers to care too, would fall in that. So difficulties, she didn't have any health insurance, so getting her to some place where she would be safe essentially, was really a priority for this patient. So the reason I put this case in here was to kind of say, well, where does she fall on this level? What level of care does she need, right? And this is really challenging for a patient like this, right? Right now, she clearly needs the level 4, right? She's all the way up at the inpatient level. But after this brief stay in inpatient, what's that? Did you say something, Cameron? Okay. She's probably up at the level 4 right now, and most of us would probably agree with that. But the problem is, what do you do with this patient? How are you going to downgrade them? Is there really a discrete level of care here where they fall into? And I argue that the answer is, in reality, probably going to be no, based on what we're able to get her. I think we did end up finding her something, that a residential program that was intended for pregnant women. But it was a challenge, especially with her psychiatric needs, and autism being as severe as it was very challenging to get a program that would accept her, or have her really, have meaningful time while she was at that program. So it was a very challenging patient. Anyone have any comments or questions on that?
I want to say that in the social part of the biopsychosocial, we have lots of patients that they do have the difficulty with their, really basic needs. And there are not too much of the support on that part when it comes to the, mini clinic that they are working to help the patient with the substance use. So hopefully that there are some resources is going to pop up through the really advocating for the patients on a higher level.
Anyone else? Any comments, questions? If not, I think we're getting pretty close to time, right, Veronica?
Just gonna say, if there wasn't any more questions or anything, we have 1 minute left. I'll give you guys 1 minute back. Thank you for everybody that's attended. Thank you for showing me grace for facilitating. And we will meet again in 2 weeks. And the speakers to be determined, but it is on SUD and obesity connections. So I hope to see you guys here in 2 weeks. And if you have a case, please submit, and you get all those emails on how to do so. Thanks, guys. I appreciate you.
All right, guys, have a good week.